Medicine 1. So, presenting Mrs. Yu, a 61-year-old housewife from Jharkhand who presented with EC fatigability for the past 7 months and dyspnea on exertion for the past 4 months. So, history, she was apparently well 7 months back when she started having EC fatigability. It was insidious in onset and gradually progressive and affected her daily living, daily activities. It was limiting her activities, and followed by which 3 months later, gradually she noticed her having dyspnea on exertion after walking 500 meters itself. Before baseline effort tolerance were very good. Now recently she has noticed getting down, decreasing. So baseline NIHI grade 1 and gradually progress to NIHI grade 3, insidious in onset and relieving with rest. There is no history of CVS complaint, orthopnea, paroxysmal nocturnal dyspnea, chest pain, palpitations, or syncope. And one more complaint that was we noted was she complained of dry cough for the past 1 month, and there was loss of appetite history was there, but there was no history of fever, weight loss, night sweats, no history. Past history, she's a known case of primary hypothyroidism for past 5 years and is on replacement thyroxine 50 microgram once daily, and no other medical comorbidities. And personal history, he had hysterectomy done 20 years back. She's so normal bowel and bladder habits. Personal history was normal. So for this treatment history, initially he was evaluated outside and was noted to have low hemoglobin. She was actually came here 2 years back for some other evaluation. At the time, her hemoglobin was normal, baseline hemoglobin. Recently, she was evaluated outside for this and was noted to have low HB, and 1 pint of blood transfusion was done outside. That was in 3 months back. And ultrasound abdomen done outside showed hepatosplenomegaly. So here on presentation, on examination, she came to the OPD. Her vitals were stable. She was noted to have pallor and icterus, and lymphadenopathy was present, bilateral axillary, 1 into 2 centimeter size bilaterally, and subcentimetric lymph node on the right cervical lymph node was present. Thyroid and breast examination was normal. And systemic examination, cardiovascular system examination, respiratory system examination was normal. Per abdomen, she had splenomegaly, 3 centimeter below the midpoint of left costal margin. She had splenomegaly, and cranial examination was central nervous system examination was normal. And here on initial presentation, HB was noted to be 6.3 and MCV of 77.4, and total counts and platelet counts were normal. She had indirect hyperbilirubinemia of total bilirubin 3.32 and direct 1.18. Other than that, liver function tests were normal. Routine showed urobilinogen plus, and she had elevated uric acid levels. Other than that, and initially had hypokalemia, which improved with treatment. And TSH levels on presentation 41.5, and she had anti-TPO antibodies also positive. And peripheral smear initially showed microcytic hypochromic blood picture with anisocytosis and poikilocytosis. Teardrop cells were present. Chest X-ray, initial some hilar mediastinal hilar lymphadenopathy-like features were present on the chest X-ray, but no features, no patch was noted in the X-ray. So the anemia we wanted to evaluate, that was a glaring thing which fit into the clinical picture also. So first step, as usual, the reticulocyte count was sent. It was 10.44%, and the corrected reticulocyte count was 6.1, and the reticulocyte production index was more than 2.5, which shows an adequate bone marrow response. So hypoproliferative anemia part we have ruled out, and possible hemolysis or hemorrhage, but she did not have any acute blood loss history, and she did not have any congenital history of hemoglobinopathy. His baseline HB was normal 1 year back, so mostly a hemolytic picture we are considering at this point. So hemolytic anemia we are suspecting. So step 1, first we want to confirm whether there is hemolysis or not. So for evidence of hemolysis, we have anemia, reticulocytosis, which is significant. Third, indirect hyperbilirubinemia was present, and she had elevated LDH levels 593, and low haptoglobin should be there, but we don't have the test case, so we didn't do. Anyway, she fit into the 4 of the criteria. So hemolysis we have established. So coming to the further evaluation of hemolytic anemia, there are various ways to classify, but we can approach it by either an acquired or inherited cause can be there for hemolytic anemia. We have ruled out the inherited parts. So baseline it was normal. So acquired cause, it can be either immune mediated or non-immune mediated grossly. So for that, the next step is to rule that out. So whether it is immune mediated, so it is an AIHA, autoimmune hemolytic anemia. For that, the first test to be done is a direct Coombs test. It's a polyspecific DAT. Or direct antiglobulin test. So here, so hemolytic anemia characterized by antibodies binding to the RBCs. So we are using antiglobulin to our own antibodies and look for agglutination. It has the polyspecific DAT covers for IgM, IgG, and C3. So multiple antibodies are also. So it being positive means definitely hemolysis there. So we did a direct Coombs test and it came 3+ positive. So next step is whether it is a warm or cold autoimmune hemolytic anemia. So for that we are doing a monospecific DAT, that is we are doing a separate individual testing for the antibodies. For that we did a test. So 3 patterns are possible in a monospecific DAT. Either it is an IgG only positive or a C3D complement alone positive, or both IgG and C3D being positive. So in this pattern, if the IgG alone is positive, it will be suggestive of a warm autoimmune hemolytic anemia most commonly. And if it's a complement alone, means mostly it is due to cold hemolytic anemia. It can be cold agglutinin disease, paroxysmal cold hemoglobinuria, or third, rarely warm autoimmune antibody with low IgG levels also can have only complement alone. So if there is IgG plus complement, definitely it is again suggestive of warm IAHA. So for our patients, only C3D came positive, which means definitely it is around either a cold agglutinin disease or a warm AHA with a subthreshold IgG population. These are the differential consider. So again, this only the C3D is a monospecific DAT, specific agglutination are used. So coming to now, we have confirmed definitely there is a autoimmune hemolytic anemia. Now the next is to evaluate whether it is a primary or secondary, because primary the management differs. So we have to evaluate for the primary autoimmune hemolytic anemia is just called warm AHS, just called AHA, and a primary cold AHA is called a cold agglutinin disease. So just a secondary cause I want to talk about in warm AHA, it can be secondary to infections like parvovirus B19, HIV, HCV, and EBV. Autoimmune disorders are more common in warm AHA, like SLE, scleroderma, rheumatoid arthritis, and autoimmune thyroiditis. This lady also had autoimmune thyroiditis. And lymphoproliferative disorders, malignancies, multiple myeloma, chronic inflammatory states like IBD, and some drugs, commonly used drugs like ceftriaxone, piperacillin, and methyl dope also can cause this warm AHA. And for cold, it's the difference are even lesser. The infections like EBV, CMV, and typically mycoplasma. These are the common infections that can trigger a cold AHA. And Waldenstrom's disease can be underlying that can cause this. And lymphoma, all B cell proliferating non-Hodgkin's lymphoma types, especially as lymphoplasmacytic marginal zone, small lymphocytic lymphomas can be present. And other malignancies also rarely, any malignancy can rarely produce hemolytic anemia. And drug induced, typically lenalidomide is one cause. So definitely secondary workup has to be done for this patient. And our patient is an elderly, 61-year-old, and has features of splenomegaly also. It typically in a cold AHA, the hemolysis actually happens in the Kupffer cells of the liver. The liver macrophages cause hemolysis. In a patient with a cold gluten picture with splenomegaly, definitely wanted to look for secondary causes. So our evaluation, initially ANA is a negative. And a bone marrow biopsy we did showed a erythroid hyperplasia and cellular marrow. There was no abnormality noted, no lymphoma noted in that also. And antibody titration for cold antibody 1:2. So in second we did a lymph node biopsy. Lymph node biopsy also showed a reactive changes, and secondary some paracortical expansion was present, but still lymphoma couldn't be conclusively diagnosed. So PET-CT, we entered with the PET-CT to look for uptake. It showed us splenomegaly, which is metabolically active, and multiple left to parailiac, left hilar, and borderline mediastinal lymph node with necrotic changes were noted. This is a diffuse uptake in the spleen also, in the parahilar nodes, and splenic uptake. This picture actually fit into a possible, now we are thinking a splenic marginal zone lymphoma is one thing is possible. Is still under evaluation. We are planning to do a CT guided lung biopsy for further diagnosis of this patient. So our patient, we give RBC transfer since he had failure symptoms, and now planned for CT guided lung biopsy. So just wanted to speak briefly about cold agglutinin disease. It's caused by IgM antibodies, again RBCs, and it is typically active below normal body temperature, and they will have peripheral signs like acrocyanose, livedo reticularis, and Raynaud's, because these antibodies are active only in cold temperature. Then you can ask why it is having in this velour temperature, because there can be some thermal range and amplitude are noted. Some of these antibodies, especially pathogenic antibodies like such, can have even they cause hemolysis till 30 to 37 degrees Celsius also. Warm IHA always 37 degrees Celsius, but cold pathogenic especially can have 37 degrees Celsius. So we are thinking maybe this lady has a higher thermal range causing hemolysis at room in a normal temperature also. And the cold agglutinin titer here would be more than 64. We are repeating the titers also since she had low titers, but it again could be a warm AHA with a low IgG levels also. So the treatment typically involves avoiding cold exposure. Anti-complement therapies are currently being used, and anti-B cell therapy like rituximab, these are being tried. Steroids are not effective, and splenectomy, as in warm IHA, is not effective here since most of the hemolysis are happening in the liver. And so, all this causes due to some lymphoproliferative change. So steroid may not be beneficial, but anti-B cell therapy are definitely beneficial in this condition.
Okay, Narendiren, I think I'll stop you for now.
Yes.
Anyway, thank you so much. And what happened to your patient?
So she's been planned for a CT lung biopsy today.
Okay. And did you actually see this patient had anemia, jaundice, splenomegaly? This is the clinical presentation. Did you give a differential based on that? So that's the most important thing, right? So when the patient, so this is a clinical meeting, so you did approach this patient very well, as in like how you would approach it, very lab based, but clinically you should have put up that these are my differentials, this is what I'm thinking, and how you're using your investigations to clinically basically to kind of differentiate those differentials that you have made and come to a diagnosis. So that the differential diagnosis is something that's very important, which you should have actually focused on, because otherwise every patient with anemia and splenomegaly, we don't go in this algorithm. So these are my differentials, these are the possibilities, and this is how I would rule out. So based on this, you would know in the beginning itself that lymphoma would be a possible differential. So that's something that you need to kind of, and what are the other, there are a lot of few infectious causes that could also be differentials for this. So those are things that you need to kind of bring into this thing. But otherwise, I thought you discussed the approach quite well, but this is supposed to have more of a clinical approach to this. Okay. Sure. Any other questions from anybody? Okay, sure. Thank you so much. So this brings us to the end of today's clinical meeting. As in, I think we've had a lot of interesting cases today, and it makes it difficult for me to give the best presentation of the day award. But looking at the different aspects, the clinical aspect, and how you approached it, and how you managed your patient, I think I would like to give this award to Dr. Brightlin. Okay, that brings us to the end of today's meeting. Thank you.